All right, here we go. AHIP Studio. AHIP Study Hall, Class 4 Mario Brothers, Communications and Marketing Rules for Medicare Advantage and Part D plans. Buckle in, guys. This one's 70 slides. So today in our Atari adventure, we are looking at Mario Brothers for our theme. Marketing and communication rules. The Medicare marketing and communication rules apply to the following types of health plans and Part D plans. You've got your MA, MAPD, PDPs, and Section 1876 cost plans. So every rule that we're going to talk about are going to pertain to those types of plans. So third-party marketing organization and marketing representatives. For those who do not know what a TPMO is, it says third-party marketing organizations and individuals, including independent agents and brokers who are compensated to perform lead generation, marketing, sales, and enrollment-related functions as part of the chain of enrollment. The steps taken by a beneficiary from becoming aware of an MA or a Part D plan or plans to making an enrollment decision. Independent agents and brokers are those who are not directly employed by a plan and those that market for more than one plan. Agents and brokers employed by the plan are not TPMOs. In this training, we refer to TPMOs and agents and brokers employed by plan sponsors as marketing representatives. Okay, Medicare communications and marketing rules. Plan marketing representatives are subject to the same requirements related to marketing and communications as the plan sponsors. So what that's saying is that when you represent a plan, you have the same rules as the plan sponsors do. Plan sponsors are responsible for ensuring compliance with Medicare rules by their marketing representatives, including annual training. I know we are in the throes of it right now with certifications, and as soon as you get through AHIP, I hope you're jumping in and getting those done so we can update your ready to sell statuses. But yes, that is, you have to follow the rules the same as the carrier, including the compliance, because compliance is everybody's responsibility. Medicare communications and marketing rules when marketing to employer union groups. Remember, the employer and union groups have separate rules than we do. Marketing representatives and plan sponsors must follow all marketing rules and guidelines when marketing to employer and union group health plans, except for the following. They do not have a prohibition against unsolicited contacts, the prohibition of cross-selling to other products, requirement to obtain proper documentation of a SOA, the prohibition against providing meals at marketing events, so union and employer groups can provide meals, the pre-enrollment checklist requirement, as well as marketing representative compensation requirements. They are paid differently than a regular street agent, and some of this is on the test, not a lot about this. Marketing reps, you do need to know this bottom part that I typed at the bottom. Marketing reps must pass a yearly test to complete annual training. Employer union plans do not need to send marketing materials to CMS up front, but CMS can review them if needed to check for accuracy. What I typed in the bottom is what you're going to see on the test. 2 questions on the test. Marketing reps must pass a yearly test and complete annual training. Employer union plans do not have to send their marketing materials to CMS unless it is requested for accuracy. Agent and broker requirements. Plan sponsors must contract or employ agents and brokers that are licensed by the state in which they conduct relevant sales and marketing activities. That is on the test. Agents and brokers must be appointed by the plan if required under state law. Medicare Advantage and Part D plans are required by law to ensure that all employed and contracted agents and brokers complete training at least annually. That includes all content specified by CMS. They must pass a written test each year that demonstrates thorough familiarity with both the Medicare program and the products they are selling. Agents and brokers marketing employer union group plans are not required to be tested. However, plans may choose to require testing. That bottom box is on the test. Agents and brokers marketing employer union group plans are not required to be tested. However, the plan may choose to require it. Marketing and communication defined. There is a huge difference between marketing and communication. Marketing is with intent to sell. Communication is relaying information. But here we go. Communications are materials and activities that provide information to current and prospective enrollees on Medicare health plans and Part D plans. Marketing is distinguished from communications only material and activity based on intent and content. Marketing activities and materials are generally subject to a higher degree of regulation and oversight. That is true. So to sum that up, and I'm sure the next slide I may be jumping ahead. So to sum it up, the communication pieces like education, things that involve being informative, that is so different from marketing. Marketing is going to talk about benefits, why they are doing so great and why they should select that plan or why they should select that agent. And marketing activities is going to be setting up a table somewhere or conducting a marketing sales meeting versus an educational meeting. But we'll dive more into that. What is marketing? To be considered marketing, the material or activity must include both marketing intent and marketing content. Marketing intent is the purpose of marketing activities and materials is to draw prospective or current enrollees' attention to a plan or group of plans or to influence a beneficiary's Medicare Advantage or Part D plan choice, including a decision to remain enrolled in their current plan. So retention is marketing. I cannot stress that enough. Retention is marketing. Marketing content, marketing activities and materials include address content regarding any of the following: information about benefits or benefit structure, information about premiums and cost sharing, rankings such as comparisons to other plans, Part D sponsors, measurement standards such as star ratings, plan rewards, and incentive programs. So I believe it's Humana, I don't remember off the top of my head, but they have a Go 360 incentive program to encourage beneficiaries to complete tasks, whether it's for mental health or physical health, and they get rewarded. That is marketing. Mentioning a broad category of widely available benefits, such as dental, vision, hearing, or premium reduction, provides information about benefits, then becomes marketing content, regardless whether the details are provided about those broad categories. So anytime they're going to start talking about, that's why when we set up these educational seminars for our agents, we say, you can only talk about what's on the slide. If somebody has a question about information pertaining to a plan, they need to schedule time with you. They need to call you. You need to be in front of them with a scoped appointment to where you can talk about these details. Otherwise, you have just turned an educational event into a non-compliant marketing event. Marketing activities: presenting health plan benefits to Medicare beneficiaries with intent to steer them towards plans sold by a particular agent or agency. Participating in an event where health plan brochures and a summary of benefits are distributed. Meeting with the Medicare beneficiary to discuss upcoming benefit enhancements by reviewing the annual notice of change known as ANOC, and to encourage them to remain enrolled in their current Medicare plan. I will always say that every time I read this, retention is marketing. Passing out plan-specific benefits information, agent business cards at a health fair is also a marketing activity. Accepting enrollment forms and performing enrollment at marketing sales events. Those are all things that are marketing activities. Marketing materials are direct mailings, newspaper, websites that promote specific plans and discuss general benefits or their star ratings, scripts or outlines for telemarketing, enrollment, or other presentations, brochures promoting enrollment in a plan, discussing the plan's reward programs for receiving preventative care services, presentation materials such as slides and charts explaining the benefits of enrolling in a particular plan, and social media. You will see Anything pertaining to social media, there are quite a few questions this year regarding social media, so you want to pay attention to those. And they do refer to that as Twitter, now X, in their questions, just FYI. So social media posts such as Facebook, Twitter, now X, YouTube, etc., that mention a plan star rating, note is low premium or promote its benefits. All of that is marketing. The regulation of marketing materials and activities. CMS regulates marketing activities in many ways, including the setting of which you can do it, who may market, timing, contact, content, and review and approval. The setting, CMS has rules about marketing in a healthcare setting versus marketing in other settings, and marketing at educational events versus marketing events. They also say that CMS requires marketing representatives to comply with state laws concerning licensing. CMS places strict limits on marketing by healthcare providers. CMS regulates when marketing representatives can begin marketing in the next year's plans. Pop quiz. When can we start talking about 2026 plans? October 1st. Contact. CMS regulates how marketing representatives can contact potential enrollees. The content is CMS requires certain disclaimers or other information to be included in marketing materials. That's why when we vet our communications, any of our marketing materials, anything that we do, we get it approved through CMS. And the bottom cannot be cut off. There is a SMID code, and there's also disclaimers at the bottom that are necessary to be on there, because if they relate that marketing material back to us, we all get in trouble, including you, the agent. CMS also prohibits the use of certain claims or language such as free, best, number one, whatever. Review and approval. CMS requires that all marketing materials be submitted to CMS for approval and review. Materials developed for use with employer or union group members do not have to be submitted to CMS. But as we learned earlier in this module, CMS can require to review them for accuracy. Any questions about marketing versus communication only? And we're starting communication only. Quiet, you bunch are. Communication-only materials and activities. Communication-only materials and activities provide information to current and prospective enrollees that contain no marketing content or includes marketing content but does not have marketing intent. For example, CMS designates certain materials that have marketing content, such as an EOC or a summary of benefits, but it's not marketing material. It's informative. A targeted letter sent to a plan's members may be intended to encourage those members to receive certain preventative services they have not yet received and refer to cost sharing for those services. While it contains marketing content, it would not meet the marketing intent, because the plan is simply letting them know, hey, you need to go get your colonoscopy. It is free of charge. Because it's your preventative colonoscopy or whatever the case may be. I'm just making stuff up at this point. Communication only material content. CMS does not require communication only material to be submitted for review and approval. It may review such materials and does require certain disclaimers to be used in those materials. CMS also prohibits the use of certain claims or language in those communications. CMS does require certain designated communication materials critical to beneficiaries understanding or assessing their benefits to be reviewed, such as EOCs. CMS may require prior review of communication materials that, based on feedback such as complaints or data gathered through reviews, warrant additional oversight to ensure accuracy. That will be on the test. The bottom one, CMS may require to review the communications. Contact. CMS regulates how marketing representatives can contact potential enrollees. For example, agents may not make cold calls, even if they limit their conversations to a communications content. Other content, CMS requires or regulates what marketing representatives may say to enrollees and potential enrollees. So let's dive in. Rules that apply to all communications. Plans and their marketing representatives may not mislead, confuse, or provide materially inaccurate information to beneficiaries. Target enrollees based on income levels, except for in the case of dual eligible special need plans, DSNPs, because it's not that we're targeting them, it's just we have to discuss the fact they're on Medicaid. Target enrollees based on health status, except for in the case of the chronic special care special needs plans. We do that. We have to ask if they have a heart condition. State or imply that the plans are not available to seniors rather than all eligible beneficiaries. The way I like to say that is now that you're becoming Medicare eligible. I never say turning 65. I don't use any of that verbiage. I always use now that you have are becoming eligible for Medicare, or since you are eligible for Medicare. That's how I combat that personally. Solicited contacts. Marketing representatives are prohibited from marketing unsolicited contact with beneficiaries, including through door-to-door solicitation, including leaving flyers or door hangers at a residence or on someone's car. We've had a boss before that was determined that we should put notes on people's doors or give them to the apartment manager. We told him it was not right. Door-to-door contact unless an appointment, and not at Medicare Compare. This is at a carrier that Charlie and I used to work at. Door-to-door contact unless an appointment at the beneficiary's home at a scheduled date and time. Approaching beneficiaries in common areas such as parking lots, hallways, lobbies, sidewalks, stores, or parks. Telephone calls without a scope of appointment where the planned business exception is not met. Text messages and other forms of electronic direct messaging, social media platforms like Facebook, instant messaging. That would be like through Messenger on Facebook. Voicemail messages after unplanned calls. That's not to say for your current clients, if you need to call them. I know that I personally reach out to get things scheduled the first 2 weeks of October to do a plan review. They're already my client. Scopes are good for a year. So it's just, I do that before the AHIP, and I will leave voicemails, but that's not an unplanned call because it's me doing my agent duty to my clients. Marketing representatives may not make unsolicited calls about other businesses as means of generating leads for Medicare plans. So if you are in the financial services world, you're not supposed to use your people for Medicare to generate leads for Medicare. Now, if they ask you about Medicare, totally fine. You cannot make unsolicited contact based on the referrals or leads provided by enrollees or other sources. However, they may leave business cards with beneficiaries to share with their friends and family. The other thing, and I say this every year, I love whenever I talk to people, I tell them to save my number in their phone, and I'm perfectly happy for them to share it with anybody they would like, because that gets them calling us. And that I do leave cards as well, but if you leave cards and they're at the grocery store, the chances of them having your card on them is slim. So I encourage you to also encourage people to put your name and number in the phone and not to keep you a secret. Beneficiaries who are voluntarily disenrolling may not be contacted for sales or retention purposes or be asked to consent to sales contacts. Agents may not make calls to beneficiaries who attend a marketing event unless the beneficiary completed a consent to contact form or scope of appointment. Permitted contacts. You are allowed to initiate electronic contact through email with an opt-out process to no longer receive electronic communications. So there has to be that mechanism. If you are going to reach out to people via email, make sure you have an opt-out option. Return calls or messages from individuals who initiate contact and request information. Call beneficiaries who have asked to be contacted by filling out a BRC, which is a business reply card, or asking a customer service rep to have an agent contact them. Business reply cards, BRCs, and requests to contact are only valid for 12 months following the beneficiary signature date or the date of the beneficiary's initial request for information. Call beneficiaries to confirm an appointment that has already been agreed to by the beneficiary. So calling to make sure they're going to be at the time that we have scheduled is perfectly acceptable. Call beneficiaries who submit enrollment applications to conduct business-related enrollment. Business-related to enrollment, sorry about that. Marketing representatives, which is you, an agent, may call current enrollees of the plan sponsor or its parent organization, the entity that owns controlling interests in the plan sponsor and is not owned by another entity. I don't know why it says that. Including those in non-Medicare health plan products to discuss plan business. For example, they may contact individuals enrolled in one of the MA organizations or its parents' commercial health plans when the individual is aging into Medicare. I know that I am the first one to jump up and down whenever I talk to somebody and they're like, so-and-so contacted me. And I'm like, they're not supposed to. Here's the deal. If they have Blue Cross Blue Shield at work, Blue Cross Blue Shield will notice that they're turning 65 and Blue Cross Blue Shield absolutely can contact that individual. It's completely permitted. Contact the MA organization's Medicare plan enrollees to discuss Medicare products. Call members in Part D plan offered by the plan sponsor to discuss other Medicare products. You can do all those things. Contact MA organizations, Medigap enrollees regarding MA, PDP, or cost plan options. You can call current enrollees of a plan to discuss, inform them about general plan information, such as annual enrollment period dates, availability of flu shots, upcoming plan changes, educational events, and other important plan information. Back to what I was saying earlier, everybody needs to start laying out a plan now for how you're going to contact your clients before the annual enrollment period from October 1st to October 15th. You just need to start thinking through that. And we will be connecting with our agents to discuss books of business and our ideas, but just get that while you're going through these certifications, you're going through AHIP, have that at the forefront of your mind on you need to schedule time because inevitably plans are going to change, formularies are going to change, things are changing every year at a faster rate than previous years. So make sure that you have that in your mind, especially those on PPO plans. Let's see what else. Call a beneficiary who marketing representatives enrolled into plan, discuss plan business, as well as the availability of other plan options types within the same parent organization. However, if the plan sponsors or its representatives reach out to beneficiaries regarding plan business, the plan sponsor must provide notice to all beneficiaries whom the plan contacts at least once annually in writing of the individual's ability to opt out of future calls regarding plan business. Rules for sales and educational events. I will tell you the test is solely based on this. Okay, not solely. I'm being a little exaggerate here, but there's a lot, so pay attention. Sales events are events designed to steer potential enrollees toward a plan or limited set of plans or encourage current enrollees to remain in their plans and include discussions of premiums, benefits, star ratings, rewards, incentives, or distribution of marketing material. Again, educational events are events designed to generally inform potential enrollees about Medicare, including MA, Part D, or other Medicare programs, and do not include marketing materials or activities. Educational events may be held in public venues. Educational events may be put on by providers or other groups and or sponsored by one or more of the health plans. That is on the test. It's going to be there's two different questions, and it may go into this a little bit more, but the educational events may be put on by providers. The way the question is worded is, can a provider attend an educational event? Yes. Marketing events are prohibited from taking place within 12 hours of an educational event in the same location. That too is on the test. They're going to give you a scenario, and you need to know that it would need to be scheduled the next day in at a different location. The same location is defined as the entire building or adjacent buildings. So you can you can't go next door within an hour or two and do it again. You have to schedule it 12 hours after. Advertisements and invitations in any form of media that are used to invite beneficiaries to a marketing or educational event must include the following statement: for accommodation of persons with special needs at meetings, call, and then we insert all that information. Plans must submit presentations that include marketing content to CMS before use at a sales event. At sales event, agents may discuss plan-specific information such as premiums and benefits, discuss plan star ratings, discuss the merits of a plan, distribute and collect enrollment applications, distribute plan-specific advertisement, explanatory information, and general information about Medicare, provide refreshments and light snacks as long as they are not bundled and provided as a meal. That's the exact answer to the question. So when you see all of that, it'll come right back to you. You also may collect scope of appointment forms for future personal marketing appointments. Prohibited activities at sales events. At marketing sales events, agents may not require beneficiaries to provide contact information to attend the event. This includes requiring an email address or other contact information as a condition to RSVP for an event online or through the mail. You may not have sign-in, or you can have a sign-in sheet, but they must be labeled as optional. You cannot require them to sign in. Conduct health screenings, health surveys, or other activities that could give impression of cherry picking. So if you get invited to a health fair and they're doing blood pressure or diabetes checks, you cannot sell anything there. The only thing you should be doing is you use your education only tactics. You cannot provide meals or multiple snacks, refreshments bundled to provide as if a meal, regardless of value. And you cannot use information collected for raffles and drawings for sales purposes. So if you are bringing a door prize and letting people give you a ticket or fill out a name on the ticket, you cannot use that information to sell them insurance. It's a no-no. All right, any questions? Okay, let's keep going. Required and permitted activities, educational events. Educational events must be explicitly advertised as educational. At educational events, marketing representatives may engage in activities and distribute communication materials, use a banner with the plan sponsor name or logo, distribute promotional items, including those with the plan name, logo, and toll-free number and or website. These items must be free of marketing content and be provided consistently with gift promotional item rules, must be provided to all without obligation, and must be under $15 retail value. I want to explain something about retail value. Retail value means that's how much it costs. So if it's on sale, 3 for $15, but normally they're $20 a piece, you cannot do that because normally they're $20 a piece. You have to look at it from that perspective, not the sale price. Presentation free of marketing content to educate beneficiaries about the different ways they can get their Medicare benefits. We have an amazing Medicare 101 presentation. Have a healthcare provider make an educational presentation on wellness or another healthcare related topic. You can answer beneficiary initiated questions about Medicare health and or drug plans, offer opportunities to voluntarily exchange beneficiary contact information, including BRCs, excluding scope of appointment forms. See how AHIP is tricking you? Because in a couple screens before, it said you could do scope of appointments. Now it's saying that you cannot. We need to go with this one. You can definitely use BRCs. You cannot have scope of appointments at the educational event. You may distribute business cards so that the beneficiaries can initiate contact, provide meals, refreshments, or snacks as long as they comply with the gift promotional item requirements, including the nominal value requirement. When an event has been advertised as educational, marketing representatives may not conduct a sales or marketing presentation, discuss, display, or distribute plan-specific premiums, benefits, ratings, or other marketing content or marketing materials. You may not engage in marketing activities or distribute or collect enrollment applications. You may not set up future personal marketing appointments. So you need to hand out the business reply card, and then that's as far as it needs to go. Make available or obtain completed scope of appointment forms. You cannot do that. So if you're in an in-person educational event, I always like to give away pins, and we have those. If you work for us and you do those, we'll get you some. And you can use a business reply card, and it's optional for them to fill it out. Otherwise, hand out your card and they'll call you if they would like to. During the presentation, you can say that numerous times. Contact me with any questions. Call me. My card is right there. That's my cell phone number, however you want to do it. Gifts and promotional items. Just take a picture of this. You'll need it. Section 112AA, A5 of the Social Security Act prohibits offering or giving anything of value to a Medicare or Medicaid beneficiary that is likely to influence the beneficiary to order or receive from a particular provider, practitioner, or supplier any item or service covered under Medicare or Medicaid. There is a nominal value of $15 exception to this rule. So you can provide items again as long as it's under $15 retail cost. So if you find a $200 TV on sale for $15, that will not work. Marketing representatives may provide gifts, prizes, or promotional items to beneficiaries as part of an event or for marketing purposes, as long as the nominal value exception is met. The gift or prize is not in the form of cash or a cash equivalent or rebate, and the gift is provided regardless of enrollment and without discrimination. Gifts are of nominal value if an individual item is worth $15 less based on the retail price of the item. It does not matter if the plan or representative pays less for the item. When more than one gift is offered, this one you need to know as well, it cannot be more than $75 aggregate per person per year. So if you see somebody at all of your things and you're giving away $5 gift cards, just make sure that they don't get $75 worth. In the case of a raffle or drawing, the total fair market value must not exceed the nominal per person value based on attendance. So if there is 100 attendees, you have $1,500 that you can go spend for your prize. Plan sponsors must include a disclaimer on all material promoting a prize, drawing, or any promise of a gift that there is no obligation to enroll. Gifts and promotional items. Cash.
We have a question real quick. Can an agent collect applications without a 48-hour scope of appointment at a sales event?
No, not unless it's the last 4 days of the enrollment period. Charlie, you can feel free to answer those questions too if you'd like. Okay, just trying to slow my heart rate back down. Cash equivalent includes gift certificates or cards that can be readily converted to cash. General gift cards that are not restricted to specific retail chains or specific items and categories, such as Visa gift cards. Gift cards for retailers or online vendors that sell a wide variety of consumer products, such as Walmart, Target, and Amazon. You cannot have a debit card, a gift card that can be used for a more limited selection of items or food would not be considered cash equivalent, such as Starbucks or Shell Gas gift card. Rebates would include, for example, a discount on the first month's premium or a copayment. Any questions? I see somebody's hand is raised. Charlie, is somebody's hand still raised?
I'm not seeing it.
Okay, it just has yellow. It must not have gone from my screen. Okay.
Okay.
Where was I? Oh. Personal individual marketing appointments are those tailored to an individual or small group, such as husband and wife. They are not defined by location. You need to know that in just a minute. Scope of appointment. Here's where we jump into this. 48 hours before any marketing appointment, marketing representatives must identify the types of product and products that will be discussed and obtain the scope of appointment. Types of products include MA, PDP, cost plans, and Medicaid plans. There are 2 exceptions to the 48-hour rule. Where the scope of appointment is completed during the last 4 days of the relevant election period, unscheduled in-person meeting initiated by a beneficiary. This includes when a beneficiary unexpectedly walks into a marketing representative's office or attends a sales appointment set up for another individual. Those are the limited 2 things in ways that you do not need the 48 hours but for the scope of appointment. A new SOA is required if the beneficiary requests information regarding a different plan type than previously agreed upon. Scope of appointments are valid for 12 months from the date the beneficiary signs it. Do we have any questions, since we did have an earlier question about SOAs? All right, I guess I answered that. Scope of appointments may be in writing in the form of a signed agreement, including an electronic signature by the beneficiary or a recorded oral agreement. Any technology, conference calls, fax machines, designated recording lines, prepaid envelopes, and email can be used to document a scope of appointment. Agents may not agree to the scope of appointment on the behalf of the beneficiary. So the beneficiary is going to have to sign it. If they have the inability to complete the signature, you will have to do a verbal scope of appointment. Scope of appointment documentation. Plan sponsors and their TPMOs are expected to include the following documentation in the scope of appointment: product type the beneficiary has agreed to discuss, date of appointment, beneficiary and agent contact information, written or recorded verbal documentation, and a statement that the beneficiaries are not obligated to enroll in a plan. Their current or future Medicare enrollment status will not be impacted, and clearly explaining that the beneficiary will not be automatically enrolled into any plan. Vital. Individual marketing appointments. During individual appointments, marketing representatives may distribute plan materials such as enrollment kit or marketing materials, provide educational information, discuss benefits, premiums, and cost sharing, distribute, accept plan applications, review the individual's needs of the beneficiary, including not limited to healthcare needs and history, commonly used medications, and financial concerns. Not whether they want to invest or not, but what are their concerns as far as cost sharing, premium, things like that. Talk about plan rewards, incentive programs, provide and collect enrollment applications. During individual appointments, marketing representatives may not discuss healthcare related products that were not agreed upon and documented in the scope of appointment, business reply card, or request to receive information. It is valid for 12 months following the date of the signature. Healthcare related products include Medicare health plans, Medigap plans, and dental plans, but not accident only plans. You may not market non-healthcare related products. Non-healthcare products such as accident only policies, life insurance, annuities may not be marketed during a Medicare health or drug plan appointment. You may not market additional health related lines of plan business without a separate scope of appointment. Any questions about what you can and cannot do during marketing meetings and appointments? Okay. Social media. Plan sponsors and their TPMOs must submit to CMS any social media, Facebook, Twitter, now X, YouTube, LinkedIn, TikTok, scan code, or QR code posts that meet the definition of marketing. Specifically, those that certain marketing content such as benefits, premiums, and cost sharing or star ratings. This includes such posts by agents. Social media posts are subject to marketing and communications content requirements, prohibitions on using certain language, any required disclaimers. Republication, which is a repost, that means you shared it, of an individual's post, content or comment that promotes a plan's or a Part D product, from social media platforms is considered a product endorsement, testimonial, and must adhere to the guidance and testimonies. Agents must provide CMS-approved marketing materials or CMS-created marketing materials. Use only CMS-approved submitted talking points and presentations during sales events. Before enrollment, ask CMS required questions and make sure the beneficiary's needs and a health plan's choice are fully discussed. Topics includes whether the beneficiary current providers are in network, prescription drug coverage and costs, including whether the beneficiary's current prescriptions are covered, cost of healthcare service, premiums, benefits, and specific healthcare needs. Call recording. Independent agents, brokers, and other TPMOs must record all sales, marketing, and enrollment calls with beneficiaries in their entirety. This includes recording audio portion of calls occurring via web-based technologies, so such as your CRMs and things like that. HIPAA and confidentiality and beneficiary information. We must comply with federal and state law regarding the confidentiality of individually identifiable health information known as PHI and any confidentiality obligations in their business associate contracts with plans. PHI includes any information about an individual's health care coverage, payment, or health condition. HIPAA regulates both the use, and take a picture of this, guys. HIPAA regulates both the use of disclosures of PHI. Marketing representatives may only use and disclose PHI on behalf of the plans they represent. If a marketing rep hires someone else who will handle the PHI for them, they must have a business associate agreement to protect that PHI. Plan sponsors need clear written consent before using enrollee information to market non-health products. Marketing reps cannot use or share an enrollee's PHI for marketing non-plan reasons without the enrollee's written consent. Beneficiary information collected by a TPMO, including agents for marketing or enrolling them into a MA cost or Part D plan, may only be shared with another TPMO when prior written consent to share the information and be contacted for marketing or enrollment purposes is given to the beneficiary. The beneficiary's prior written consent must be obtained through a clear and conspicuous disclosure that lists each entity that would receive the data and allows the beneficiary to consent or reject the sharing of their data with each of the TPMOs listed. Independent agents and brokers and other third-party marketing organization must use the TPMO marketing disclaimer if they sell plans on behalf of more than one plan sponsor. If the TPMO does not sell for all plan sponsors available in the service area, the disclaimer, we do not offer every plan available in your area. Currently, we represent insert number of organizations which offer insert number of plans, products in your area. Please contact Medicare.gov or 1-800-MEDICARE or your local state health insurance program known as HIPAA to get information on all your options. If the TPMO sells for all plan sponsors in the service area, the disclaimer is listed there. You're more than welcome to take a picture of it. The disclaimer must be A, verbally conveyed within the first minute of a sales call, B, electronically conveyed when communicating with beneficiary through email, online chat, or other electronic means of communication, C, prominently displayed on TPMO websites, and D, included in any TPMO marketing materials, including print materials and television advertising. Take a picture of this.
Hey, Taryn, I have one quick question. So does the verbal scope of appointment that the call center gets when we get our lead, does that satisfy the initial phone call?
Yes. That is done 48 hours in advance. That's why they're scheduled 2 days later. Unless they completed one online and we got that earlier, we may schedule it sooner. But absolutely, that is what counts as a scope of appointment. And we do follow the compliance rules.
Great. So
Absolutely.
I don't have to go through that each time I call someone in the first minute because that's already been handled for me.
Oh, you're talking about the disclaimer or the scope of appointment?
The scope of appointment.
Okay, scope of appointment and disclaimers are two different things.
Okay.
Yes, you do have to read that in the first 1 minute of any recorded call.
Okay, perfect. Thank you.
Yeah, you're welcome. Okay. Any other questions? Special rules related to lead generation. TPMOs conducting lead generating activities must disclose to the beneficiary that their information will be provided to a licensed agent for future contact. This disclosure must be provided verbally when communicating with a beneficiary through telephone, in writing whenever you're communicating with the beneficiary through mail or other paper, electronically when communicating with the beneficiary through email, online chat, or other electronic messaging platforms. If the lead generating TPMO transfers a beneficiary to an agent, the TPMO must disclose to the beneficiary that they are being transferred to a licensed agent who can enroll them into a new plan. Those who obtain leads from such entities should ensure all of these requirements have been met in generating the leads and include this obligation in any contracts with the lead generating TPMO. Beneficiary information collected by the TPMO for marketing or enrolling may only be shared with another TPMO when prior written consent is given by the beneficiary. And I would take a picture of this as well. It's a little bit in this module exam, and I know that they change them out, and the one I took may not necessarily be the one that you're taking, but it is in the final. Marketing activities. Plans are required to post documents in a downloadable format on their website. You can see all of those there. Such documents are important tools to be used by marketing representatives in determining issues such as who's the network, all the things, formularies, and we do that through Sunfire, but all the plans are required to have that information on their websites that beneficiaries can also access. Required materials with enrollment form. When a beneficiary is provided with enrollment form, they must also receive star rating information, a summary of benefits, and pre-enrollment checklists. Beginning September 30th, 2025, so this will go in effect on October 1st for the 2026 plan year, the notice of availability of language assistance services and auxiliary aids and services, notice of availability will have to be also on there. The beneficiary must also receive notice of availability when provided with any other CMS required materials such as EOCs, ANOCs, or summary of benefits. For DSNPs, if Medicaid benefits are not included in the summary of benefits, a separate document including the Medicaid benefits must be included with the enrollment form. So specifically what that's talking about is when what I call a core plan, a non-DSNP or special needs plan, coordinates with Medicaid in some areas. It will list, obviously, any information we give them is going to give them the cost sharing for the normal plan for a beneficiary who does not have Medicaid. And that piece of paper that will be included and will be sent to them will identify those issues. When a beneficiary enrolls online, the plan must make these materials available electronically to the potential enrollee before submitting the enrollment. For telephonic enrollments, the contents of the pre-enrollment checklist must be reviewed with the prospective enrollee before completing the enrollment. So I am sure it will, we will be getting that information, what we're going to be required to disclose, like through Sunfire and stuff, as we always see when we do telephonic enrollments. Beneficiaries must be told verbally where the summary of benefits and star rating documents may be accessed. And I always give them the website that they may go on to for the plan. CMS releases star ratings that allow beneficiaries to compare MA plans and Part D plans. These ratings are based on measurements such as whether members got various screening tests, vaccines, and other checkups to help them stay healthy, and how members rate the plan on topics such as access to care and customer service. You can obtain a plan rating information at medicare.gov. The star ratings information document must also be prominently posted on each plan sponsor's website, and new plans Part D sponsors that do not have any star ratings information are not required to provide that. That is a trick question on the test. Star ratings information until the next contract year. So if there's a new plan coming into market, then like I've noticed, Devoted pops up in new markets every year. They're not going to have a star rating in Oklahoma because this is going to be their first year in Oklahoma, but they would in other states such as Washington and Illinois. Plan ratings. Plan sponsors and their marketing representatives provide the plan's overall performance ratings to beneficiaries in standard plan ratings information document. May only reference or mention a plan's rating on an individual measure in conjunction with the plan's overall performance rating for MAPD, Part C summary rating for MA only, or Part D summary rating for PDPs. What it's saying is, if they get 5 stars for customer service, they only get 4 stars for this mark, and they only have 4 stars, and their overall rating is maybe 4.5 stars. Just because they got 5 stars in one category does not mean it's a 5-star plan. It would have to be 5 stars in all categories in order for them to say that they are a 5-star plan. That is also true if they have 3.5 stars in one area and 4 stars in another. They have to go with the overall stars. We cannot say that this is a 4-star plan when we can clearly see that maybe customer service has a 3.5 stars. Plan ratings, what not to do. Plan sponsors and their marketing representatives may not use the plan star rating in an individual category or measure or imply overall. Use the plan star ratings in a manner that misleads beneficiaries into enrolling plans based on inaccurate information. Use updated star ratings until CMS releases star ratings on the Medicare Plan Finder, and continue to use old star ratings 21 days after the release of new star ratings. So you have 21 days after the new release, and sometimes when people do, especially those of you who do in-person activities, you get materials delivered to you by the carriers. You'll be receiving separate packet of information with new star ratings that you need to put inside any information you hand out if you do in person. Marketing representatives must not market any non-healthcare related products during any MA or Part D sales activity or any other marketing activity for existing enrollees. This is considered cross-selling. If you notice, this year, I did take particular notice of this. Read that top sentence again. Market any non-healthcare related products during any MA, or Part D sales activity or any other marketing activity for existing enrollees. So if you're making a sales call, not just checking up on them, you cannot bring up any cross-selling opportunities. State that the plan sponsor will not disenroll individuals due to failure to pay premiums. Display the name or logos of provider co-branding partners on marketing materials unless the materials indicate via a disclaimer or in the body that other providers are available in the network. Marketing and communications. Marketing representatives must not use Medicare beneficiary to endorse a plan unless the beneficiary was an enrollee of the plan when the endorsement was created. So if somebody used to be on the plan, you sold them 5 years ago, but now they moved over to PACE and they're no longer on that plan, they cannot give you a testimony. Solicit enrollment applications for the following contract year before October 15th, unless the beneficiary is entitled to another enrollment period, such as becoming eligible for Medicare. Use marketing materials that have not been submitted by the plan for review approved by CMS. Charge beneficiaries marketing fees. I have seen a lot of this on social media. Agents across the whole entire nation have been very verbal about this. There are people who are starting to charge, especially for PDP sales, for their services. It says right here, you cannot charge marketing fees. To me, that is saying you cannot charge a beneficiary to do a formulary lookup for them for a PD plan, whether they pick a plan that pays commission or not. That is my take on that, and I stand by that. Do not do that. Engage in bait and switch strategies, such as making unsolicited outbound calls to beneficiaries about other lines of business as means of generating leads for Medicare plans. Again, if you are trying to generate leads for Medicare plans, do not engage in bait and switch by calling to say, hey, let's talk about your annuity and how it's growing or not growing. And then, oh, by the way, Medicare, you can't do that. Discriminatory activities, I can never say that word. Alex, how do you say that? Superlatives, superlatives, and comparisons. Marketing representatives. Do what?
What did you want me to say? Unsubstantiated superlatives?
Superlatives. I cannot say that word. Thank you.
Okay, you're not being tested on your vocab today. So
I am kind of.
This isn't the ACT, I don't think.
Okay. Marketing representatives must not engage in any discriminatory activities, such as attempting to recruit Medicare beneficiaries from higher income areas without making comparable efforts to enroll Medicare beneficiaries from lower income areas. Encourage individuals to enroll based on their health status unless it is focusing on a special needs plan. Conduct health screening or other activities that could give impression of cherry picking. Use unsubstantiated, whatever, best, highest, rated, best value, etc. Superlatives may not, did I say that right? Superlatives? Oh my goodness, I did. May only be used if the sources of documentation or data are supportive and of the superlative. Make explicit comparisons between plans unless such comparisons are factually based and are not misleading. You may not engage in marketing practices that may mislead or confuse beneficiaries, such as providing false and misleading information about the plan, including benefits, provider rules, and other plan information, such as claiming that a PFFS plan is in the same as the original Medicare or Medigap plan. Just a minute. I need to send a notice to somebody real quick because we are going to run over. Actually, Charlie, I'm sorry, I'm going to be rude. Charlie, I need you to have the call center call my 3 o'clock. Until then, I'll be late. Misleading marketing practices. Marketing representatives must not engage. I already read that. Providing false or misleading information about a plan. Read that. Claiming the Medicare, CMS, or any other government agency endorses or recommends the plan. Medicare and CMS do not recommend the plan. People used to say we are recommended by Medicare or CMS. The plans are approved by them, but they are not recommended. Using the Medicare name, CMS logo, and products or information issued by the federal government, including the Medicare card, in a misleading way. Use of the Medicare card image is permitted only with authorization from CMS. I am guilty of this. I do a lot of marketing on social media, and I have pulled it's red on top, white in the middle, blue, so it goes red, white, and blue, because we always say get your red, white, and blue card out. Apparently you're not supposed to use those anymore. Advertising benefits that are not available to beneficiaries in the service area where the marketing appears unless the advertisement is in local media that serves the service areas where the benefits are available, and reaching beneficiaries who reside in other service areas is unavoidable. Marketing products or plans or benefits or costs unless the plan sponsor's name of the marketing names of the plan sponsor offering the products or plans, benefits, or costs are identified in the marketing material, including information about savings to beneficiaries that are based on comparison of a typical expenses borne by uninsured individuals, unpaid costs, or dually eligible beneficiaries, or other unrealized costs of a Medicare beneficiary. You must not use the term free to describe a $0 premium. Instead, use $0. Use the term free in conjunction with any reduction in premiums, deductibles, or cost share, including Part B premium buy down or low income subsidy or dual eligibility. Use them correctly, not the word free. Lead beneficiaries to believe that the broker or agent works for Medicare, CMS, or any government agency. That comes into play when people ask, how much do I owe you? You owe me nothing because Medicare's pay me. That's wrong. I make a commission through the plan. That would be correct. Imply that a plan operates as a supplement to Medicare. When you're talking about Medicare Advantage, it is not a supplement. It is a Medicare replacement plan, Part C. It doesn't mean they lose Medicare. They must have A and B, in fact, to be enrolled in Part C, but it is not a supplement. Dual eligibles, unless they are promoting a DSNP, marketing representatives must not claim that the plan has a relationship with the state Medicaid agency unless the MA plan or its parent organization has contracted with the state to coordinate Medicaid services, and the contract is specific to MA plan, not for a separate DSNP. Market a non-dual eligible special needs plans as if it were a dual eligible special needs plan. Target marketing efforts for the plan exclusively to dual eligible individuals. Marketing during the OEP. Here's the short and sweet of it. I'm not going to read all this. We are out of time. During OEP, you cannot say that you have a one-time change unless somebody comes to you upset, not wanting to be enrolled in the plan. The only things that you can market during OEP is your typical marketing tactics, going after those who are becoming eligible for Medicare, maybe C-SNP, maybe duals, anything, educational events, but you cannot use the MA OEP January 1st through March 31st as a marketing tactic. However, we do get calls in during the OEP, and we do, as agents, we do move plans. Part D is not included in the OEP. I get that question a ton. Part D does not have a one-time change. If they got on the wrong Part D plan or they didn't read their annual notice of change, unfortunately, unless there's another reason, another special election period, they cannot change their OEP. They cannot change their Part D during OEP unless it's a part of an MAPD. Marketing in the healthcare settings, it has to be in common rooms. It cannot be in where they're doing labs, tests, or where the doctor would visit to do a visit for their health. It has to be in common areas. You can provide communication materials to be distributed and displayed in the healthcare setting. I'm going to send this one up for you too, and this is on the test. Just go ahead, get your phones out, take a picture. But marketing in long-term care facility. You can set up a table and they can come to you if they would like. You can host events, but you cannot just go into rooms. Those are the rooms. You cannot just show up to their room and sell them insurance. It needs to be a scheduled visit. If they schedule it, you absolutely can go into their room if you have a scheduled time and appointment with them. And also the facility cannot collect enrollment forms for you at all. They can call and request you to come visit with somebody, but that's at the beneficiary would need to schedule an appointment. Oversight, plan oversight and enforcement. Plan sponsors must establish, implement, and oversight. Take a picture of this. Plan that monitors agent activities, identifies noncompliance with CMS requirements, and reports noncompliance to CMS. Plans are required to implement a strategy to prevent prohibited marketing practices from occurring, detect those that are not allowed, and take immediate corrective action to respond to noncompliant marketing activities. Plans must take disciplinary corrective action in the event of verified misconduct. Examples of such disciplinary action include withholding or withdrawing commissions, retraining, suspension of marketing, termination, other consequences outlined in the contract with the plan. Reporting and cooperating with states and CMS, plans must comply with requests from the state insurance department during investigation of licensed marketing representatives. Plans must report to states the termination of any agent, including the reasons for the termination if required by state law. Plans must also report to CMS any for-cause agent broker terminations. This has happened recently within that I am aware of that I've had to address, not with me, but in another situation. We do have to let them know when it is for cause terminations. And if a plan finds that you have done something illegal, that is a for cause termination, and CMS will be notified. You will not be able to go to a new upline and recontract. That's why you may try, but you'll probably get denied, and then you'd have to work with CMS on how to get back on the right track. Plans must report to CMS all enrollments made by unlicensed agents or brokers. Upon CMS's request, the plan must provide CMS with information necessary for it to conduct oversight of marketing activities. Plan sponsors must require TPMOs, including independent agents, to disclose plan sponsor. Any subcontracted relationships used for marketing, lead generation, and enrollment report to monthly plan sponsors. Any staff disciplinary actions or violations regarding beneficiary interactions with the plan. Changes to compensation set to begin for 2025 enrollments and Texas district decisions. Take a picture of this. I'm not going to read through it, so I'm going to give you about 10 more seconds to get your phones out and take a picture. Okay, if anybody needs that, just let me know and I'll email it to you. Referral fees. Plan sponsors and their subcontractors may pay individuals or entities for referrals and potential enrollment into a plan, may not exceed $100 for a referral into MA or MAPD, or 1876 cost plan, and $25 for PDPs. The limitations on referral fees for potential enrollment into a plan apply to all agents, brokers, including employed and captive agents, as well as any other individuals or entities. Compensation includes monetary or non-monetary compensation of any kind related to the sale or renewal of a policy, including but not limited to commissions, bonuses, gifts, prizes, and awards. Compensation structures for independent agents must comply with CMS. Independent agents are those who sell for multiple plans and are not employed by a plan sponsor. Compensation rules do not generally apply to marketing representatives who are employees to captive agents who market to only one plan, or when independent agents are marketing only to employer group and union groups. Compensation to independent agents who market to enroll beneficiaries is covered by the rules, whether it is paid directly by a plan or paid by an agency, field marketing organization, FMO, or another TPMO. The limitations on referral fees for potential enrollment into a plan apply to all agents and brokers, including employed captive agents, as well as any other individuals or entities. When compensation may not be paid is when an agent has not been trained and tested, does not meet state licensure requirements, when they have not been appointed by the plan in compliance with the state law, and rapid disenrollments. We did have to do a chargeback recently. Somebody did not know that that was a thing and thought that was exclusive to our FMO. Guys, it happens all the time. It happens at the carrier level. It happened to me. Actually, I enrolled somebody, it went into effect, and then they passed away. The commissions had to be recouped because that person is no longer paying in, or, the plan is not being provided money for that. So it happens. It doesn't necessarily mean you did anything wrong, but it does happen. To continue receiving renewal fees, agents must remain trained, tested, licensed, and appointed to the extent required under state law. So that's each state law that you are licensed in, regardless of whether they are actively selling. You have to continue to do that in order to receive your renewals. Compensation must be paid on a calendar year basis, regardless of the month the beneficiary's initial year enrollment. The renewal year begins on January 1 of the subsequent year, not on the enrollment anniversary. It is January 1st. So anybody that you enrolled this year, you will start receiving renewal income on January 1st. Plan sponsors have the flexibility to make compensation payments annually, quarterly, monthly, or by different schedule. However, they must pay compensation during the year of enrollment. Compensation may only be paid for the months the beneficiary is enrolled in the plan. If the plan pays compensation in advance, it must recoup amounts paid for months a beneficiary is not enrolled, just like I was explaining earlier. If a beneficiary enrolls mid-year, compensation must be prorated. Exception to pro rata payment rule. A plan may choose to pay for an entire initial year enrollment despite less than 12 months of enrollment for a beneficiary who has never been enrolled in Medicare health plan before, or where a beneficiary moves from an employer group plan to a non-employer group plan. If the plan pays a full initial compensation and the enrollee disenrolls during that contract year, the plan must recoup a prorated amount for all months the enrollee was not enrolled. If a beneficiary disenrolls within the first 3 months of enrollment, it is called a rapid disenrollment. The entire compensation amount paid for the enrollment must be recouped, except under certain circumstances. Plans do not have to do that if the plan enrollee is effective October 1st, November 1st, December 1st, and uses AHIP change plans for the effective date of January 1st. If they became dual eligible or Medicare or Medicaid, qualified for another plan based on special needs, became LIS eligible, or lost Medicare entitlement. Again, my name is Taryn. That's Charlie. We're always available to help you.